Thank you for joining today's webinar, Advancing Health Through Accountable Communities, a Conversation with States. This is Jill Rosenthal. I'm a Senior Program Director at NASHP, and I want to welcome you and thank you all for joining us today. The webinar is presented by the National Academy for State Health Policy with support from the Robert Wood Johnson Foundation. We'll be focusing today on Accountable Communities of Health, or ACHs, and how states are rolling out these new community-based structures to improve the health of their populations. We've invited 4 states to join us today to describe how they arrived at this model, what ACHs look like in their state in relation to transforming health systems, strategic decisions they're making about financing and implementation, and how we can all learn in real time to accelerate lessons from states that are testing these models. First, a little background to provide some context. NASHP recently released a report on ACH initiatives in California, Minnesota, Vermont, and Washington. The report, State Levers to Advance Accountable Communities for Health, explores the evolution and status of ACH initiatives in these states. As you'll see, in each state, a partnership of state agencies, or in California's case, a public-private partnership, is rolling out the model in a limited number of communities with some support from the State Innovation Model Initiative and other sources of funding. Accountable Communities for Health are slightly different in each of these 4 states, but what they hold in common is that they are community-based structures that have as their goal improving population health by addressing social factors that influence health. They're developing in states that recognize that health is more than health care, and that achieving the triple aim of improved care, better health, and reduced health care costs requires engaging community partners in new ways. Although ACH models are unique to each state, they do share some commonalities that are evident in the criteria that they must meet to become designated as an ACH. They must engage partners in a shared mission and vision. They must establish the infrastructure, which includes financial, data, administrative functions, as well as governance, to be operational. They must undertake activities or interventions that engage the community in population-based health promotion interventions. These interventions focus on a continuum of strategies to improve community health, from improving health care for individuals with existing medical conditions by coordinating care for individuals with multiple health and social needs, to facilitating community-wide environmental approaches. They all also require what is called an integrator or backbone organization, which is an organization, for instance, a local health department, a hospital, or another type of community-based nonprofit organization that convenes partners and guides ACH activities. These states acknowledge that ACHs must be community-driven to meet community needs. However, they also envision ACHs as a component of a broader statewide delivery system and consider their development in this context. States can and are leveraging resources to support the development of ACHs, such as seed money and technical assistance, and are exploring mechanisms to support their sustainability and spread. The speakers on today's webinar will discuss the unique features of their emerging ACH initiatives. Our panelists for today are Sarah Kinsler, Senior Health Policy Analyst with the Department of Vermont Health Access Vermont Healthcare Innovation Project, Barbara Masters, Project Manager for the California Accountable Communities for Health Initiative, Chase Napier, Community Transformations Manager, Washington State Healthcare Authority, and Rosemarie Rodriguez-Hager, Community Integration Practice Transformation Unit with the Minnesota Department of Health. You can ask questions at any time during the webinar by typing them into the chat function on your screen, and we will address them during the open Q&A at the end of the presentation. So I'd like to begin now with the first question for our panel, and that is, how does your state's ACH model fit into larger delivery system reform? And for the first answer, we're going to turn to Rosemarie in Minnesota.
Hi, good afternoon. In Minnesota, in 2011, MDH funded community care teams to pilot an implementation of community and provider partnerships around care coordination. And this was a 12-month competitive grant initially funded through our healthcare home program here at the Department of Health. It included multidisciplinary care teams, which included clinics, healthcare homes, local public health, hospitals, community, and social services. The focus was on coordinating care for whole patient, engaging all sectors, and developing new relationships and approaches to coordinated care. In 2010, DHS developed and implemented IHPs as a demonstration to test alternative healthcare delivery systems, which strives to deliver higher quality and lower cost healthcare through innovative approaches to care and payment. There was a goal of improving the health of the population and of individual members. They bring together healthcare, behavioral health, long-term supports and services, and community prevention services that are coordinated and centered around patient needs. There are currently 19 integrated health partnerships that are serving 342,000 Minnesotans enrolled in medical assistance and are delivering better care at a lower cost. This led to our Accountable Communities for Health, which are funded through the state innovation model. And they are innovative strategies to meet the clinical and social needs of a defined population through person-centered coordinated care across a range of providers. SIM grant really acted as a catalyst and incentive for providers and organizations and communities to move toward greater integration of community services and organizations in these models, as well as greater focus and shared accountability for population health. The ACH model requires involvement from the community. It's a community care team and an accountable care organization. There really is a focus on the whole person, taking into account social determinants of health that may affect the health of the person and the population. Our Accountable Communities of Health are one part of the Minnesota Accountable Health Model's vision that builds on a robust foundation of health reform activities that have been underway in Minnesota for a number of years. And our approach will provide needed resources and investments to accelerate Minnesota's care delivery transformation to achieve the triple aim of improved population health, improved patient experience, and lower cost. And that is great.
Thank you, Rosemarie. All right, now let's move to Vermont. Sarah, can you tell us about how your ACH model fits into larger delivery system reform?
Absolutely. Thank you, Jill. As Jill mentioned, in many states and in Vermont, the big goal is to develop an integrated health system to achieve the triple aim. We have a few major efforts underway now in Vermont that we think will really help us get there, and this graphic shows our thinking on a high level. So on the left side, you'll see the all-payer model and Medicaid pathway initiatives through which we intend to align value-based payment strategies across Medicare, Medicaid, and commercial payers in the state. And I'm touching on these just very, very briefly to put the work that we'll talk about today in context. On the right side, where we'll spend most of our time talking today about Vermont's initiatives, we have the set of complementary delivery system reforms, which are supporting system integration and care integration, as well as building provider readiness to participate in payment reforms. Vermont's payment reform activities, current and planned, and our Accountable Communities for Health efforts are building on more than 10 years of work to build a high-performing clinical system in the state and to connect that to social and community services. This includes many of the initiatives you see here in the blue box, including the Blueprint for Health, Vermont's statewide multi-payer patient-centered medical home program, the Blueprint Community Health Teams, which bring in some social and community services to support primary care, our SASH program, or Support and Services at Home, which serves elders in public housing, and our Hub and Spoke Health Home initiative, which targets opiate addiction. Then down towards the bottom of that blue box, I'll just note that as in Minnesota, SIM has really acted as a catalyst with SIM support and in partnership with the Blueprint and with Vermont's ACOs. We're also providing technical assistance to provider organizations through provider learning collaboratives and are in the process of developing regional governance through what we call unified community collaboratives that can support quality improvement, practice transformation, and community clinical linkages. All of this is in the context for our Accountable Communities for Health Peer Learning Lab, which includes 10 participating regions of 14 in the state. So on this slide, you see our unified community collaboratives are the critical regional building blocks for healthcare governance in Vermont, and have in most communities provided the foundation for our ACHs. UCCs were originally formed to combine regional blueprint and ACO governance, which were in danger of becoming duplicative and siloed, and those are the light orange boxes coming in from the sides. The blue boxes on the top of the slide here are the original UCC membership, which in most communities spans clinical care, including acute and ambulatory care, mental health and substance abuse, and some long-term services and supports with social services as well. I'll note here that the UCCs have varied significantly by region, which is a major theme in Vermont that we'll touch on a little bit more later. Vermont has put significant effort across the Blueprint ACOs and SIM into developing these collaboratives and supporting communities in developing governance structures and charters, identifying community-wide priorities, and taking on some initial projects. But until now, most of our unified community collaboratives have lacked a strong link to prevention and population health. And we see our ACH Peer Learning Lab as an opportunity to really jumpstart that connection. The blue boxes represent healthcare and social services. The green boxes are representing health. The Peer Learning Lab provides technical assistance, a new framework, and a set of tools that can bring new partners into community transformation, including community prevention coalitions, Vermont's Department of Health, and a broader set of community partners.
Great, thanks, Sarah. So let's move now to California. Barbara?
Great, thank you so much. So our ACH model dates back to the state's Let's Get Healthy California Task Force, created by Governor Brown and led by our HHS Secretary Diana Dooley in 2012. The goal of the task force was to identify what the state, not just the government, but the public and private sectors together needed to do to become the healthiest state in the country. This represents the overarching framework, which identified 6 goals, 3 population-based goals and 3 systems-based goals. And one of the systems-based goals was creating healthy communities. With the SIM design grant in 2013, and you can move to the next slide, the state then developed initiatives as part of the innovation plan under each of Let's Get Healthy California's 6 goals. The ACH was designed to address the Healthy Communities goals. A stakeholder group was established and the initiative emerged from that process. I also want to mention that along with the initiatives developed under the Innovation Plan, there are many other system transformation efforts underway in California, including the Section 2703 Health Homes, which also was identified as part of the Innovation Plan, and several initiatives under the recently renewed Section 1115 Medicaid waiver. One of those initiatives is what we're calling in California the Whole Person Care Pilot, which seeks to coordinate health, behavioral health, and social services, especially those services that address key social determinants of health. These initiatives are primarily targeting high-cost, complex patient populations who use multiple systems. We see the ACH as complementary to those efforts in that it is designed to take a whole population approach and address a spectrum of population and disease states, that is, already present disease, people at risk, and those individuals who have not yet developed that condition or disease. I should point out that the health homes and 1115 waiver are being implemented concurrently with the ACH. So counties or communities have not yet been selected for either the Whole Person Care Pilot or the health home. And we're anticipating some ACH sites may in fact overlap with those initiatives, and they will then need to figure out how to coordinate, leverage, and even integrate these activities to minimize duplication of infrastructures and efforts. I want to point out that 6 sites have been selected and span for the ACHs and span the state to the extent that 6 projects can span a state as large as California, but 2 are in large urban counties, 3 are in medium to small cities, and 1 is in a rural county. So we'll have the opportunity to test the model in a variety of settings and market dynamics. Next slide, please. We did not receive implementation funding from CMMI for the ACH initiative. So a group of private funders stepped up to support the initiative, and I just wanted to acknowledge them.
Blue Shield of California Foundation, California Endowment, Sierra Health Foundation, and Kaiser Permanente. The state is a partner with the funders and is supporting 2 projects in conjunction with the initiative. The first concerns data sharing, since we know this is a critical issue for an ACH and a huge challenge for most communities. And then the second project involves the development of an evaluation framework to inform the evaluation which will be undertaken by the initiative. And I believe it is the intent of the California Department of Public Health to share that framework with other states to the extent that it could be useful for their evaluation efforts.
Great, thanks, Barbara. And now let's move to Washington. Chase.
Great, thank you, and good afternoon, and good morning to those of you near Washington State. And I'm going to cover the overarching strategies first and then talk about the connection to our accountable communities of health. You can see our map on the screen there. Building healthier communities through a collaborative regional approach is one of the 3 main strategies of Healthier Washington. We also want to make sure that our healthcare system is addressing all of the needs of the individual through a whole person care approach. And then we want to improve how we pay for services, which gets to our value-based payment efforts and some of the payment models that fit within that, along with our measurement system and our work with our managed care partners. So if you think about the connection between those 3, to improve how we pay for services, it really leads back to the whole person care approach, and recognizing that health is not defined in one setting or one silo, and even extends to the community. And that leads us to that approach through collaboration at the local level with our community partners. And so in Washington, we do have 9 accountable communities of health that span the entire state. They really represent the entire continuum of care and the experience of the individual, where they live and work, and where they receive care is at the community level. And we recognize that, one, we have to have the conversation there. We have to create a more formal partnership with our communities if we're going to change the way we pay for health care, and if we're going to change the health system to really think about health as the entire experience of what factors into health. We have to take that conversation to the community, and we also have to bring in other partners that may not traditionally be considered part of the healthcare system. And so our ACHs represent those variety of partners from the education system, criminal justice, housing, and other determinants within the community, but also the delivery system, our providers, both physical and behavioral health providers, and our health plans and managed care partners. And so that's one thing that I want to emphasize that's part of our model, is intentional alignment with our Medicaid managed care system. So the regions that you see there for the accountable communities of health are identical to the regions for our Medicaid purchasing boundaries. And so the partnership is very intentional, that as we work with Medicaid, even though the ACHs and Healthier Washington is entire population, that as we work with our Medicaid partners and our managed care system, that's a starting point as ACHs begin to engage with health plans and engage with providers that are really being incentivized for this approach of whole person care and value. And we need that partnership, and we need that collaboration to make that come to life. And so this regional service area for Medicaid purchasing and the Accountable Community of Health partnership, that alignment is very intentional, and we have strong partnerships that are in place. So we'll talk a little bit more about some of those different components, but that's the overarching purpose of our ACH model.
Great, thank you, Chase. So I think you can get a sense from these 4 states that they are all building on existing innovations and looking at opportunities for improving health for populations. So moving on to the next question, I mentioned at the beginning that ACHs provide a continuum of services and interventions. So Barbara, I'm going to ask you if you could talk about your state's framework for community health improvement.
Sure. Jill went through the common elements of an ACH across the various states. In addition to those elements, we called out a definitional element to be what we're calling a portfolio of mutually reinforcing interventions, which is a mouthful, but it conveys the important concept that an ACH must develop and implement interventions across 5 key domains to address the selected issue. And we did this because we believe there is no single intervention or magic bullet for improving population health, and that you need to align, coordinate, and to the extent possible, integrate interventions to achieve lasting change. We also wanted to make sure that the ACH didn't just focus on clinical interventions or the high-cost, high-need populations, which is often the case when you have a 3 or 4 year initiative and there's an ROI at play. Finally, we wanted to make sure that the ACH is taking a prevention-oriented system transformation approach. Although policy and systems changes can span upstream or downstream interventions, it is the case that many upstream interventions live in the policy, system, and environmental change domains, so we made those categories explicit. Although this is only a 3-year initiative, we wanted each grantee to make sure to include these last 3 domains, policy, systems, and environmental change strategies, even if they have a longer-term time frame associated with when outcomes may be produced. To be clear, we are not looking for a laundry list of activities, but rather a set of interventions that are strategically connected and which can potentially create synergy with each other. In our RFP, we developed this sample portfolio regarding diabetes to convey what it is we're trying to get at. And as you can see, there are clinical interventions, such as improved adherence to care guidelines in primary care, that can produce short or medium-term outcomes. Community and social services interventions, such as the YMCA Diabetes Prevention Program. And there may be other types of interventions here that address social determinants of health that may be relevant to the selected health issue, whether it's housing, food security, etc. Third domain, which we felt was important to make explicit, is the linkage between the clinical services realm and the community and social services sectors. Too often, these programs and services are working independently. There's not a lot of partnering that goes on, and we think to be really a holistic ACH type infrastructure, you need real explicit partnerships. So we identified potential strategies as the integration of community health workers who really do straddle community and clinical teams, or referral systems between clinical and community programs. And we've been researching various efforts to implement these kinds of referral systems. And then finally, we identified policy, systems, and environmental change domains. We separated them because there are policy and systems changes that can apply to the community domain, such as school changes, or the clinical services arena, such as health plan incentives. And then the environmental change domain is separated because some of those changes may or may not be the result of a policy change, so you could implement a walking group or a walking path that isn't the result of any particular policy change. But we recognize that many of these changes may not produce outcomes for several years past the time frame of the initiative. But we are trying to set the stage for the ACH infrastructure to be a permanent infrastructure for the community. So we wanted the planning associated with the ACH to have that longer term time frame.
Thanks, Barbara. Sarah, can you talk about the domains in Vermont?
Absolutely. Thanks, Jill. Vermont's framework for community health improvement includes 3 levels, and I'll just say Barbara mentioned avoiding the laundry list in favor of intentional alignment and interplay between strategies on all of the levels, and I would say this connection and synergy is really the key for us here in Vermont. So I'll go through the 3 levels and talk about a little bit about each. First, traditional clinical approaches. This includes Vermont's Blueprint for Health, patient-centered medical home efforts, as well as all of the clinical quality improvement work going on throughout the state. Second, the innovative patient-centered care and/or community linkages piece. This includes our Blueprint Community Health Teams, the Support and Services at Home, or SASH program, and a lot of the SIM-funded work that we have going on to support integrated person-centered care management that really brings together healthcare providers with social services and community organizations to meet individual social needs as well as clinical care needs. And I'll just say that the need to connect to levels 1 and 2, those first 2 levels, has been a core principle of Vermont's health reform efforts for years. We have a lot of work happening that spans both of these levels. So I think one of the areas where Vermont excels is in connecting the clinical piece with the community linkages and the social services. All of that said, the third level is community-wide strategies, and though we've historically had a ton of wonderful work going on in this area, led both by the Vermont Department of Health and by community prevention and health improvement initiatives, this is an area where we've struggled to connect with those first 2 levels. So one of our goals with Accountable Communities for Health is to further develop and systematize the connections between the community-wide strategies level and the work that's already occurring to bridge the clinical and community service and social services world.
Thanks, Sarah. So California and Vermont's models are more newly emerging. Washington and Minnesota's ACHs are off the ground. So I'm going to ask Chase, can you give us an example of an intervention that would be unique to an ACH so we get a sense of what are they actually doing on the ground?
Of course, yeah. And I want to say here, when we think about ACH activities, and I'm going to give you an example of a project that's underway, I just want to note that there's really a parallel effort that our ACHs are both partnering with the state on systems transformation, really big picture, healthier Washington, our shift to value-based payment, working, as I said, with our managed care partners, and the list goes on. In addition, we're trying to support specific activities that the community is really interested in. So it's not defined by a specific domain, such as our value-based approach and other investments under Healthier Washington, but really a community-driven collective impact approach. So one example with Cascade Pacific Action Alliance, a 7-county ACH, they talked a lot about adverse childhood experiences, behavioral health needs, and other resulting impacts and the needs associated with those impacts. And so they worked on a behavioral health risk assessment process. So they're really partnering with their school systems, their primary care physicians, pediatricians, behavioral health providers, and other local partners. And what they've done is implemented a behavioral health risk assessment tool within the school system. And I believe they're in 4 counties now, and they're looking to spread to other schools and other counties within the region. And this allows them to identify the need earlier, both in the school setting, and also their goal is to identify the needs within the primary care setting and other settings to provide the appropriate assessment and referrals to services. And again, that's not limited just to behavioral health, but also to other social supports and, as I mentioned, primary care needs. So the ultimate goal here is to decrease the number of school-age children with unmet behavioral and physical health needs. And we see what's really exciting about this is without a lot of dedicated funding, just the partnership that exists within Cascade Pacific Action Alliance, they've been able to, for the most part, leverage a lot of existing resources and existing infrastructure to support this type of coordination. There is some funding that's going towards this, but our focus is not on a lot of grant funding to go to project activities, and this is still the type of coordination that we're seeing early on in one of our ACHs, which gets back to that idea of care that really isn't just in one setting, but working across these different partners to focus on all the needs of the individual in a bidirectional way. So pretty exciting stuff, and again, early on in the process and not a lot of dedicated funding, but you can see the type of work that's starting to take shape.
Thanks, Chase. So that's a great example of a project addressing the needs of a young population. And Rosemarie, you have an example addressing a senior population?
Yes, I do. I just want to give you an example of from one of our one of the 15 ACHs that we have. Unity Family Healthcare ACH is care coordination model that was set up to mitigate substance abuse that focused on the senior population. And really the partnership formed to address the concern about narcotics use in the community, and there were a high number of emergency room visits for therapeutic drug monitoring, and also high numbers of Medicaid patients with 8 or more narcotic prescriptions. In fact, this ACH really partnership came about in response to an incident that happened in the community in which a man killed 2 teenagers who had broken into his home. And this really brought to light the incidents and the problems in the community with robberies that were targeting pills in people's homes. And so this partnership was formed initially with St. Gabriel's Health, South Country Health Alliance, and Morrison County Local Public Health. But it expanded to social services, law enforcement, local pharmacies, the school district, and Substance Abuse Prevention, the Substance Abuse Prevention Coalition. And we are really seeing some early results that are showing positive outcomes. There's a reduction in Medicaid claims for narcotics. In comparison from 2014 to 2015, for a 4-month period, there was $439,674 less paid in narcotics claims. So we are seeing the results in very early stages. And like I said, that was for 2015. And right now they're reporting over $1 million in savings. They're able to report this through their involvement of the ACO, so being able to exchange that data and see what the utilization is. And as I said, this ACH was formed in reaction to the environment in the community, but it was really formed due to the ACH solidified its entity due to the SIM grant, and has been finding additional support provided by their ACO. They received a grant that will allow them to continue their work through 2017. And in addition, they've also gained recognition. They have just come back, actually, on the 12th, from providing testimony for a congressional staff briefing. And what I've heard so far, just in their what they have communicated to us, it was a standing room only presentation. And they had staffers from all of the states and included 3 senators. And so they really are seeing, seeing that they are receiving recognition. People are interested. Congress is interested. And so we're seeing the successes of our ACHs here in activities such as these, where they have a really tight collaboration with the partners that are all playing a strategic part in the activities.
Great, thanks, Rosemary. Great example. So let's move on now to an area where I'm sure many listeners have questions about, which is your state's plan for financing and sustaining ACHs. And let's go first to Chase in Washington.
Yeah, so I have a slide up here that shows some of the complexity in Washington and the Healthier Washington system supports, which are some of the investments that are in place. And the reason I do this is because I'm going to take a slightly different spin on sustainability of ACHs. We are considering and working with technical assistance on specific models for coalition sustainability, including community wellness funds, pay-for-success approaches. We have strong partnerships with philanthropic partners within the state. So all of that is in play. But what I'm going to focus on is that we're really talking about the value proposition of the accountable community of health as we move our healthcare system to one that focuses on value and is rewarded for value, that's rewarded for health over specific services or a more traditional fee-for-service approach. And so these different supports that connect the community factors to health and recovery care, and the fact that this needs to be a coordinated system where we're really thinking about all of the different pieces that are contributing to quality, that are contributing to health outcomes, and ultimately that represent a valuable and sustainable system. The accountable communities of health in many ways comprise all of these moving pieces, and they comprise all of these partners that are represented within the health and recovery care system and these community supports and community factors. And then our Healthcare Washington initiative has some resources that are these supports that are really supporting and lifting this coordinated system up. But the ACH is what brings it all together, and if the ACH can work with our managed care system and work with our health plans and work with our providers to start to broaden the definition of health and to start to better understand within a very local setting at the community level what the needs are and what the resources are and how to make those connections and those, whether it's the transitions or whether it's the gaps in specific supports outside of the delivery system, that there are factors that are going to make this system successful or not. And so we're really emphasizing that value proposition and the role of the ACH. As that happens, we think that's where sustainability becomes more of the built-in necessity, that the community partnership and the idea of collaboration would really be a necessity for the health system. And then in addition, though, of course, we're looking at specific activities and how do you sustain that through savings and reinvestment, and again, the concepts of wellness funds, pay for success, and other funders that are within the community and are already working with the ACHs. So I just wanted to provide that angle and the emphasis that we're taking as we talk about sustainability. We're really wanting to start with, well, what's the value and why does the ACH need to exist in a sustainable system? And that's where our conversation's at right now.
Thanks, Chase. Barbara, can you tell us about California's plan for financing and sustainability?
Absolutely. Here is our schematic of how we envisioned the accountable communities for health. It's very busy. I'm not going to spend time in it on most of the elements since Jill covered most of this earlier. But I share this to emphasize that our vision for the ACH is an infrastructure that will ultimately address population health broadly for our community and a variety of community priorities beyond the one that they will be working on in setting up the ACH. We believe that sustainability has to be built in from the start. So our approach was to embed what we are calling a wellness fund inside the ACH. Interestingly, some of our selected sites actually have the foundation for a wellness fund, but most will be needing to create one as part of this initiative and create the governance structure to ensure that it is responsive to the overall ACH governance and priorities of the ACH. Each ACH will be required to develop a sustainability plan, which we hope will ultimately include some type of reinvestment strategy. That is, by bringing all the partners to the table, the ACH can identifying a common health priority and collectively developing a set of interventions to address that health priority. Can they identify reduction in costs or cost avoidances? And if so, can the ACH agree to reinvest a portion of those savings back into the ACH? And although we start with healthcare, we believe that other sectors may also participate over the long term, from criminal justice or education, if they in fact achieve cost avoidances or cost savings. It's obviously a long-term vision, but we wanted to put that on the table right from the start. So in the next slide are just some of the key attributes of the Wellness Fund as a vehicle for attracting, braiding, and blending resources from both public and private sectors, as well as potential healthcare savings, as I just described. And as Chase said, we are exploring different types of economic modeling that could be brought to bear on this issue. So ultimately, the Wellness Fund has two primary purposes. First, to support the ACH, especially the backbone organization or other functions such as data sharing that will be necessary to maintain that infrastructure. And then secondly, to support interventions, particularly prevention-related interventions, for which few resources typically exist. For example, the community health worker interventions that we talked about earlier. So that's our general approach to sustainability, but I want to second what Chase mentioned about ultimately being able to build a business case for this type of an infrastructure and build that into various types of reimbursement strategies.
Thanks, Barbara. Rosemarie, can you tell us about Minnesota?
Sure. From the very beginning for the ACHs, the state did require all of the ACHs to have a sustainability plan as part of their work. So in part, this is something that ACHs have been working on since they started. And we see ACHs doing this already with their partners, looking for funding on their own and being successful in funding certain parts of their ACHs. And so that is one way in which we're looking at sustainability. Also, really, it's important to demonstrate how engagement with the broader community partnerships impact the overall outcomes, including total cost of care. So with the work accomplished through the ACHs, we're showing the value of the work through the outcomes and seeking to expand beyond Medicaid ACOs. Also, there's just proposed continuous support for ACHs. We've had 2 years, and this takes more time to stand up these models. And as California is presenting their project, the planning that they have had and I think is going to be extremely valuable for them as they move forward. In Minnesota, as we set up our ACHs, their ACHs came together, although there were some that were already in partnership. But primarily the ACHs came together due to the funding, and so with that we've had 2 years for them to plan, create their infrastructure, and then implement their project. And so that is a short time, and so really thinking about how do we continue to support them at a state level. And then of course aligning the goals of ACHs with other programs such as our healthcare homes or the federal AHCs, which would help to support some of the activities with an ACH. And so those are some of the ways in which we see ACHs being able to be sustained in the future.
Thanks, Rosemarie. Sarah, can you talk about financing and sustainability in Vermont?
Of course. I'll just start by saying that Vermont's ACH Peer Learning Laboratory is an opportunity for us, both the state and our regions and partners in our regions, to explore a new model. Our goals for the Peer Learning Lab are to first identify practical steps at the regional and state levels to support Vermont communities in progressing toward accountable communities for health along all of the key elements that Jill identified at the beginning of the webinar today, in addition to a few others that are Vermont specific. Second, to identify necessary supports for development of core elements of the ACHs in Vermont regions. Third, to determine what we can do independently at the regional level, so without statewide intervention and support. And fourth, to inform the development of state-level policy changes and resources to support those regional efforts. So Vermont's ACH Peer Learning Lab is really a robust technical assistance and facilitation support program to interested regions. It's a peer learning opportunity for folks across regions and across sectors to come together and really spend some time together, facilitating visioning, providing a framework and some new tools, and engaging a broader group of partners in that conversation. And as we're noting here, our regions really have a lot of flexibility within this initiative. So we haven't asked them to implement a specific project, and it's a completely voluntary initiative, though we did require interested communities to submit applications to demonstrate that they had a key set of partners at the table, and to demonstrate strong interest and commitment to the learning effort. So looking forward, Vermont is really watching the peer learning lab experience. Vermont, as in the state government of Vermont, is really watching the peer learning lab experience to gather lessons and to inform future state decision making. So that's that last program goal that I mentioned. We expect the Unified Community Collaboratives to continue as core regional governance and to continue to receive support, potentially from the state as well as from our ACOs. But we also believe that this is an opportunity to bring population health and prevention activities into the fold where they've previously been a little siloed. I'll also say that many regions in Vermont are starting to independently seek new financing models, both in the short and long term. And as folks in other states mentioned, that includes both grant-based funding and thinking about how to structure their communities a little differently. Lastly, I'll note that our next steps are all in the context of our all-payer model, our Medicaid pathway, and the other care delivery and transformation efforts that I mentioned earlier, which definitely are not going away.
Thanks, Sarah. So moving on to our final question before we get to our open Q&A. And again, if you have a question for a speaker, you can feel free to chat it in at any point. The last question is about your challenges that you've faced in implementing ACHs and next steps. And so, Sarah, why don't you go ahead and start?
Sure. Thanks, Jill. Vermont's identified a couple of key ACH implementation challenges. First, Vermont's on the verge of transformative change with the all-payer model and Medicaid pathway. These parallel initiatives have the potential to really dramatically change healthcare payment and delivery in our state. And there are still a lot of moving pieces on both of these fronts, especially as we work with the federal government to come to agreement on a potential waiver. Second, Vermont's been engaged in healthcare reform for a really long time now, and individual providers, healthcare organizations, and partners around the state are feeling that reform fatigue. The volume of reform initiatives and changes mean that our community organizations and partners are stretched thin and are balancing competing priorities. So, many of them are participating in our Accountable Communities for Health effort in addition to participating in other reform initiatives, as well as in addition to their day job. Third, Vermont has for a long time emphasized local control in our health reform efforts. This has resulted in some really cool and unique initiatives in our communities, but it's also resulted in significant variation across our ACH communities, which we see as both a strength and a challenge. That regional variation allows for initiatives to be tailored to communities' unique needs as well as unique assets and priorities, but it makes pacing pretty difficult. Our regions are at vastly different stages of readiness. Some have really strong integration of healthcare and social services with community-wide prevention and are building on mature unified community collaboratives, while others are much less formed. This makes it difficult to stage a statewide intervention that meets all participating communities where they're at. Last, I'll just add one challenge that's not on this slide, which is that Vermont is small. We are really, really small. We have 14 regions in the state aligned with our health service areas, and with a statewide population that's smaller than most urban counties, there are only so many individuals engaged in implementing some very significant reforms, which magnifies the reform fatigue I just mentioned. All that said, Vermont is very, very excited about accountable communities of health, both as a concept and as a set of tools to help our communities continue to transform and move forward. And in particular, we're looking forward to see how these efforts mature both in our regions and in other states. And I think we'll be harnessing the lessons that we're gathering out of the Peer Learning Lab to make some policy decisions in the future.
Thanks, Sarah. So moving from a small state to a big state, Barbara, can you talk about challenges in California?
Sure. As we've just completed the proposal review and selection process, there are several issues that have arisen as potential issues, although we don't yet have actual implementation experience. But we are developing a TA plan to address these emergent issues, which include data sharing capacity and mechanisms, community engagement, and to varying degrees, deep engagement with health plans in each of the regions. In addition, there's the issue I spoke about earlier and which was just referenced, the concurrent implementation of several health system transformation efforts, and not overwhelming staff as they potentially get all implemented together. What I want to focus on for just a minute here is evaluation. We are in the process of developing an evaluation framework for the initiative, which is being supported by the California Department of Public Health with SIM funds. And the major challenge is how to identify and extract conditions for success when there is a fair amount of variability across the 6 sites. Each ACH is being built on a history of collaboration that exists in individual communities, where it's not being created from scratch. The 6 grantees are focusing on a variety of issues, 1 on asthma, 2 on trauma and violence, and 3 on cardiovascular disease and diabetes. 4 of the grantees have located their backbone organizations in their public health departments, while 2 are in nonprofits. And finally, there's little literature on the synergistic effects of a portfolio of interventions. That's our theory, that a portfolio of reinforcing interventions can accelerate impact, but that will be a question that we hope the evaluation may be able to shed some light on. Finally, although the initiative is only 3 years, we know that achieving real improvement in population-level outcomes is a longer-term proposition, especially when we're interested in the impacts of primary prevention. So how does the evaluation account for that particular challenge? So those are the ones that are being teed up in the development of the evaluation framework.
Thanks, Barbara. Rosemarie, what are some of the challenges you're facing in Minnesota?
Probably the first challenge that we have had is related to a decision that we had made early on for the ACH is not to have an attributable population, and instead focusing, we wanted to learn from the ACHs about their partnerships, their governance, community engagement. And so while we don't have the statistical outcomes and data in each of the ACHs, there are some that we have that data and are able to provide it. But I think that that is probably one of our biggest challenges, is being able to show the improvements that we're making for specific populations. In overall population health, there are many great activities and programs in Minnesota that are focusing on population health, and we have built on many of them with our partnerships with our State Health Improvement Project or our community wellness grants. And many of our ACHs work with those projects, either have them as part of their leadership team. But what we did not require for the ACHs is to have local public health be a partner with the ACH. And the reason for not requiring it is because there are different capacities for each of the local public health departments, and it would have put different ACHs in different geographic areas at a disadvantage if their local public health was not able to participate due to staffing or other resources. And I think also as a round 1 SIM grant, population health was not a priority. And so while we did not have a focus initially for the ACHs, this was something that was included. But in a short time period, even with the 2-3 years of the work, it is really difficult to show results on population health. So what we have really been working on is looking at the opportunities that we have to show the work that we are doing to move population health along. And then last, community engagement. This is something that requires a lot of resources, of time and support, which I'm sure everyone knows. And so there is that it takes a lot of time to build that trust and to build those relationships. And it also takes funding. And with our current funding, there's restrictions on the use of funds to be spent on items that are really important for community engagement, like food or transportation. And so that has been a real challenge for some of our ACHs who don't necessarily have the partnerships that can provide those items to support their community engagement. And then one that is not on the slide that I just wanted to mention is the exchange of data between partners. This has been another challenge for our ACHs. It has been something that it's been difficult, and we continue to look for solutions, and we provide technical assistance on it. But the issue of exchanging that data between clinics is an issue with privacy laws. But beyond that, having an ACH that has partners in social services, in county services, exchanging that data even makes it more difficult for the partners. And so that will be something that we continue to work on in other areas of our SIM grant and department.
Thanks, Rosemary.
Yeah.
And last, Chief, can you tell us a little bit about some of the challenges and opportunities in Washington State?
Yeah, I'll quickly just echo the community engagement challenge and opportunity there. And for us, it is a resourcing question. It also is one of education and awareness of the initiative and what's going on in Healthier Washington. So what's the right level of education that needs to happen, and then what's the mechanism for engagement and the location, recognizing these are regional accountable communities of health. So we are still navigating, and something we're exploring very heavily through our technical assistance. What is the best mechanism to engage different communities and different community members within the work and the different designs of what that might look like. The other one that I'll call out is the connection of community supports and upstream health improvement activities to delivery system transformation. And I say challenge and opportunity because I think that this is exactly the value that's represented by the ACH, but the conversation has been a challenge, and this has been one of the priorities of every dialogue over the last year or two, is a focus on upstream investment, which it makes sense, and we think about the partners that are around the table. There's a lot of energy and excitement about population health and getting as far upstream as possible. At the same time, we do have some focus and some levers within the delivery system and within our shift to a value-based model. With that comes specific opportunities and incentives for our managed care partners and providers. And so how do you link those two, that they're not separate? It's not one at the expense of the other, but how do you balance that approach of we are going to continue to look to upstream investments and a long-term perspective, but at the same time, we really do need to see the short-term connections between our partners that represent the social determinants of health and our partners that represent the transformation that's occurring within the healthcare system. And so that has just taken a lot of discussion to get to that balance and to start to make the linkages between, okay, what do we mean by a value-based system, and what are the measures we're going to be looking at, what are the incentives, and how is that driving the system, and then what's the opportunity there in the short term, not necessarily just long term, but how do we provide that balanced perspective. So that's been a key discussion in Washington.
Great, thanks. So those are some great questions and challenges and opportunities that have come up, and not surprisingly linked to some of the questions we're seeing in our chat feature. Again, please feel free to submit chat questions. And I'm going to start with one that builds on some of the questions you all just raised in response to the last question. So one of them has to do with the idea of authentically engaging community members. And as we see in one of the questions, it appears that the ACH initiatives really do require local level investment from busy people. And so any thoughts about maybe some early lessons or strategies for how to help communities engage busy people in this work about community health improvement?
this is Chase with Washington. I think that it's a very good point that there is so much in-kind support and just voluntary time that's provided. One thing related to that we learned early on and made as many adjustments as we could is just the emphasis on infrastructure and staffing support that this takes. And I mentioned earlier, not a lot of dedicated funding on different activities and different project or domains, but really just the support to coordinate and to bring partners together. I will say, after a couple of years, we have still very diverse representation and partnership in each of the ACHs, and so where there is that time commitment and that burden on the community that we recognize, we are also seeing a lot of energy still and a lot of commitment and just the return on that time. One of the comments that comes up a lot is having conversations about the needs and the alignment that exists within those needs and the different populations that are served by those represented around the ACH, and how they're starting to collaborate in ways that they didn't before. And maybe it's the scale that it is, across multiple communities. Maybe it is the types of partners that they're working with now. So even outside of big picture health system transformation, outside of specific projects, just that behind the scenes coordination and collaboration that's occurring, I think that's keeping them engaged. But we did really have to emphasize our support and financial support for staffing and infrastructure above most else.
This is Barbara in California, and our initiative went through an RFP process. So ACHs were people who submitted proposals for communities that were interested, had that sort of commitment at the local level to doing this kind of work. I think what we were pleasantly surprised and a bit overwhelmed by was the fact that we had a far more robust response to the RFP than we anticipated. We had 44 proposals submitted from all over the state for ultimately six grants. And although some of those proposals, kind of missed the mark, many of them really were on target to what the vision is of the ACH. And many of them had a high degree of engagement and collaboration already underway. And I think it said to us that there is a lot of energy and interest in this model that is resonating with people in communities, and that they were looking for this type of an opportunity that allows them to think about health of the whole community and not just the healthcare delivery system. We even heard from some communities that the process of developing the proposal was in and itself a transformational process for them, because it's always challenging when you're doing an RFP to recognize people put in a lot of effort and work to develop their proposals with a very competitive process that may not get funded. So it was actually quite reassuring to hear that the process itself helped them move their partnerships and their transformational efforts along the pathway.
Great, thank you. Somewhat related to that topic of community resources, there's been a couple questions that are asking about any assistance with gap analysis that ACHs might have had, maybe linking to community health needs assessments, any involvement with hospital associations. So I think those all kind of fit together in a sense. Can any of you address the relationship between hospital associations or hospitals or community health needs assessments in ACH development?
This is Rosemary. Our ACH RFP, we did ask applicants to submit their target population and the needs with the data that they were using to identify that needs. And so we recommended that they use either their community health assessments or their assessments through their local public health or through the through the hospital, depending on where they were located. And that is something that we continue to work with our ACHs on as they provide population health plans, which is one part of the work that they're doing, is making sure that they are working with the locals in their particular area. And if there are particular priorities that they are seeing that are not on the needs assessment, encouraging them to have those conversations with either the hospitals or the local public health about what they're seeing in their community, so encouraging that involvement with the assessments that are going on.
This is Sarah Kinsler from Vermont. I think this is a really good question, and I'll just say that Vermont has a little bit of a unique setup with regard to our hospital infrastructure that I think relates to this question, which I won't delve into too deeply. But as I mentioned previously, Vermont has 14 health service areas in the state, and those are aligned with Vermont's 14 hospitals, which are generally pretty well geographically distributed and in almost every area non-competing, with a couple of exceptions there. So this means that we, our health service areas and our unified community collaborative regions are very well aligned with our hospitals. So I would say hospital, community needs assessments are a significant source of data that's informing the unified community collaboratives, and in turn our accountable communities for health regions in looking at local needs and also identifying local resources. Another great resource here is our Blueprint for Health program. Does a lot of data analysis and analytics related to our primary care practices, but also kind of community health indicators across our regions. That's another key data source that our accountable communities for health and our ECCs are using to identify priorities and see where there's room for improvement.
Great, thank you. There's a question about how your state's ACH initiative intersects with the federal Accountable Health Communities initiative. That is an initiative that comes out of CMMI.
Hi, this is Rosemary. I can tell you that we have had 4 applicants from Minnesota applying for the AHC. One is our current Accountable Community for Health, our North Country ACH, and then the 3 others are partners or leads or have a tie to an ACH in Minnesota. Sorry, that was a tongue twister. So we do have 4 applicants that have some relationship with a current ACH in Minnesota.
In California, we had actually hoped that there could be some overlap and had adjusted our RFP timeline to account for sites potentially applying for both. As it turns out, there won't be any overlap between the applicants from California and to the AHC federal initiative and the grantees under ACH.
In Washington, we didn't have as much direct alignment either, but what we did see is a lot of partnership being established between potential AHC applicants and our ACH regions, and that's something we called for as the Medicaid agency. We wanted to see the type of partnership that was being established and plans to coordinate if the ACH wasn't itself going to be that coordinating organization. So we saw some alignment, but not so much from the applicant itself.
All right, thank you. Rosemary, I think you were the one that mentioned some of the data challenges. There's a question about any examples of where and how data sharing is working that supports ACHs, or the type of data that is essential to make these kinds of partnerships work?
Sure. I can give you some examples of ones that are working. Part of the ACH infrastructure was to include an accountable community organization, and many of them have IHPs that are part of their AHC. So the Integrated Health Partnerships, which are our Medicaid ACOs, are a part of the ACHs. And so in those instances, they have they're succeeding in being able to exchange that data because they're partners and have that relationship and have that exchange data ability. There's also some areas where we have seen, I'm trying to think of our emerging professions in where they're part of an ACH, and I'll give you an example of our community paramedics who are using direct messaging when they're working with the ACH, and so that has been a good example of how that has developed. But beyond those cases, we have HIPAA, but then we have the medical records rule here in Minnesota, which has even a tighter hold on the privacy issues for our medical records. And so trying to exchange data between a clinic and a social service, either the systems, a social service agency may not have an electronic health record or ability to exchange that. And then, of course, we have the issues of just the general privacy laws. Does that answer your question?
Yes, thanks, Rosemary. Are there other states that want to comment on this question about the kinds of data that is needed for the data sharing that's necessary for ACHs?
This is Barbara. So we're thinking about it in 3 levels. There's the clinical data sharing between the clinical settings and the social services agencies. There's population level data sharing, and then there's financial level data sharing in order to make the business case and do that type of economic modeling that we discussed earlier. And different ACHs among our 6 grantees have more or less capacity and infrastructure, from pretty sophisticated health information exchanges and data warehouses to those that have less kinds of capacities. As I mentioned, the state has engaged with the University of California at Berkeley to do research, like a literature review, landscape analysis, and about different types of data sharing strategies, particularly if you don't have that type of infrastructure already built, which, as we all know, can cost a significant amount of money, and to develop ultimately a toolkit to help localities do the kinds of data sharing at these multiple levels that is necessary for an ACH to be able to track enrollment, track patients, track population health improvement, and track impact. And I believe that will be made available in public when it's completed.
Thanks, Barbara. Do you have any sense of a timeline for that?
We're hoping the end of the year.
Great. I think that'll be really of great interest. Another question, great question about the challenges and solutions to addressing multiple disparate funding streams that may flow to a single community, but then pose alignment and integration challenges at the community level. Any thoughts about some of those challenges and solutions?
This is Sarah Kinsler from Vermont. I think that's a great question, and the challenge of having multiple funding streams that all come with their own very targeted accountability and reporting and, metrics and, requirements is definitely a challenge we know well in Vermont. And I would say that's less something that we're addressing directly through our Accountable Communities for Health work and more through our Medicaid pathway effort that I touched on briefly, which is really looking to support, breaking down of silos and creating a more integrated system, especially with respect to providers that are predominantly Medicaid funded, those kind of Medicaid-specific services. So I'll just say we know that that plays a critical role. We see how that plays out in communities as we look at our Unified Community Collaboratives and our ACHs. We see what a struggle that is, and the state is really working with providers and private sector stakeholders as well as within state government to figure out how we best move forward to align those to reduce the burden and to reduce the burden and of that creates on integration for providers going forward to figure out how to kind of create a more aligned system.
Thanks, Sarah. Barbara, do you have any thoughts about that? Is that it seems like would be an issue that might come into play with wellness funds?
Yes, I think that is going to be an issue we've identified. As I mentioned, though, we have not yet implemented the Wellness Fund, but that will be something that we'll be working on with our local communities. We are hoping that one of the things that emerges from this process are some policy ideas, policy recommendations about how to facilitate grading and blending of resources in something like a wellness fund. So could a wellness fund attract a portion of a government grant or a portion of other types of resources? But I do think there will be some policy changes that will be needed in order to do that.
Great, thanks. There's a question about how ACH implementation can increase health equity. Any comments?
This is Barbara again. I think that this question relates very much to the discussion we were having earlier about community and resident engagement, which is, I think, at its core strategy about equity. And I think that's why it is such an essential part of an ACH. So I think if the ACHs are prioritizing and investing in community and resident engagement, that can go a long way to helping to address equity. For our initiatives, we prioritize addressing low-income communities, communities of color, and conditions that have health disparities. So all of our 6 sites will be working towards promoting health equity.
Thanks. Any other? Oh, go ahead, Chief.
Case in Washington, the other thing I would add, in addition to the community engagement, authentic community member engagement, is the conversations that are happening in Washington with our Accountable Community Health partners and the different organizations that are represented and the populations they serve. When we're starting to broaden the conversation about healthcare, I think we are talking about those factors that contribute to disparities. And so I think in addition to the engagement aspect, the nature of the work and the conversation and trying to redefine healthcare in some ways is in itself contributing to health equity. So that's not going to happen overnight, but it's definitely, I think, occurring through the many conversations in our Accountable Communities of Health.
Mrs. Rosemary, I would agree with what both have just said, is that it is really crucial to have the people who are most affected by whatever it is that you're dealing with, to have them represented at the table, to be a part of that leadership team, to really be their own voice at the table, to ensure that we're not making decisions about people based on what we think, but it's based on what their perspectives are, what they know the solutions are, and how do we ensure that they're implemented throughout the system.
Great, thanks. I know one of the common elements across the states is the provision of technical assistance by the state to the ACHs, and I think some of the areas we've talked about were data sharing, the value proposition and business case for investing in population health, blending and braiding funding sources. I'm just wondering, are there other areas where you expect you'll be providing technical assistance or where you may be engaging consultants in supporting ACHs?
This is Rosemary. We have a consultant who provides technical assistance to all of the ACHs, and that includes monthly webinars on topics like population health or sustainability. They also do cohort calls. So if there's a specific topic that they have seen has been requested for technical assistance, we will organize a cohort call around that, and it could be 1, 2, or 3 cohort calls to discuss that. We also have had we have 2 in-person meetings a year for the ACHs to get together, and it's an opportunity for them to see each other and really learn from each other. And we find that those experiences have been really the best because they really get a chance to talk to each other one-on-one about what they're learning and what their solutions are. And so that has been the way we provide technical assistance in addition to our internal experts, whether it is from DHS or MDH on specific topics that ACHs are looking for.
This is Sarah Kinsler in Vermont. We, in addition to providing technical assistance to participating communities on the 9 core elements of an ACH that Vermont kind of identified in our pre-work prior to this initiative, and we are also working really hard with our communities right now to help them do the visioning and facilitated collaboration that we think is going to take for them to really form into ACHs. So that takes a couple of forms. We, like in Minnesota, we also have kind of in-person and distance learning events. So we have in-person meetings 3 this year, as well as I think it's going to end up being 3 or 4 webinars this year to help communities kind of move along that path to an ACH. But we also have community facilitators, and that's in some cases folks from each of the communities that are taking on a special role within their group, and in some cases it's folks from the outside who are working with our communities to help them get there and help them form those systematize those bonds and those working relationships.
We're also looking to providing technical assistance regarding governance. Some have pretty strong governance already in place, but we know, especially if a wellness fund is going to be embedded, that governance will be critical to decision making and ultimately a distribution of resources from the wellness fund. Others talked about areas that we also are exploring, including collaborative leadership, financing, and sustainability. And then the last one is around the portfolio of interventions. Although clearly a lot of what was proposed, people are expert in those particular issue areas, but I think helping them think through what a portfolio looks like, what mutual reinforcing interventions looks like, so we move from a laundry list to a more strategic set of interventions will be an area we're going to focus in on.
And this is Chase in Washington. I would I agree with everything as far as technical assistance topics. One thing we learned is just engage the ACH partners early and often in identifying the need and shaping some of the technical assistance. I think that's been one of our successes is bringing them into that and giving them that opportunity. The other support role would be around specific activities and identifying what's measurable, what do we have data for, and what's the theory of change around those activities. And so that's part of our evaluation effort in addition to the TA.
Great, thank you. I think this is a question you may all have raised, but it came up again about generating savings by investing in social determinants. I think it's probably too early in these initiatives, but can you all, or can anyone talk about how you see the potential to capture delivery system savings, how to identify where they accrue and reinvest them in population health?
Well, this is Barbara. I think this is an area that we are going to be investing in some modeling assistance. There's some modeling that to build on where people have been able to identify return on investments for single interventions. And I think our challenge is to be able to model where you have this multiple series of interventions and start identifying how that may impact healthcare costs, and then attributing those healthcare cost savings to, is it the health plans, is it hospitals, is it the criminal justice system for the area where for those ACHs which are going to be focusing on trauma and violence. So there's some modeling that needs to be done. I think there's some work that has been underway that we've seen in the literature, but I think this is a fairly new arena to try to figure out how to do that and then how to allocate and attribute. I think ultimately the way we're thinking about it is this will need to fit with the governance of the ACH and the governance of the Wellness Fund and agreement amongst those partners about how to allocate those savings and reinvestment into the ACH.
And in Minnesota, the incentive for shared saving has really helped encourage healthcare providers to strengthen community partnerships, recognizing that they have a tangible incentive to also identify other services providers who can be impactful in supporting their attributed populations. Building and maintaining those relationships takes time and resources that are typically not reimbursable. So flexibility in the use of the shared savings has been important for reinvesting connections where a direct impact or return on health outcomes can be demonstrated. Right now the state has encouraged but not been prescriptive about requiring reinvestment in specific population health initiatives by the accountable entities. And we're continuing to learn from the ACHs and also our IHPs, our Integrated Health Partnerships, about the partnerships that make sense for them in their communities. And we've also solicited feedback in an RFI about updating the IHP model. So emerging examples have included support for transitional housing, to stabilize a person's condition so it doesn't put them at risk for losing their spot in the home, or creation of healthy foods, a healthy foods help desk, or food security supports that are specific to a certain chronic disease such as diabetes. And so for these to be impactful and sustaining over a long term, it's also important for them to be community driven and responsive to local resources. And so I think, and I'm sorry, I don't know who spoke just before me, but as she said, we're still in that learning process, but we are aware of what the needs are and moving in that direction.
Great, thanks so much, Rosemarie. So I want to thank our speakers.
Jill, I just want to, I'm sorry, this Barbara, I just want to make one other point with this economic modeling. I think we'll need to do this in partnership with our state agencies and policymakers, because I think there are concerns about whether, how that might affect rates. If you can determine costs going down, will that affect what ultimately are being paid to the health plans and to the providers? So we do need to make this a policy discussion as well as a modeling discussion.
Absolutely. Thanks for pointing that out, Barbara. It's a big issue that is coming up among a lot of stakeholders. So again, I want to thank our speakers for sharing their models and experiences, and I think you've provided some really good information for those states that may be falling behind you. I also want to thank the Robert Wood Johnson Foundation for supporting the webinar, and ask all of you to please complete our evaluation. I also want to point out that we do have a place on our state reform website where you can post comments or raise questions related to our webinar today. So if you go to our site, and the link is here, you can find Advancing Health Through Accountable Communities on that page and post a comment or a question. And again, thank you all for joining, and we look forward to providing updates on these initiatives as they evolve. So thanks so much.